Good afternoon. It is a big pleasure to be here. So thanks so much, Miss, for that kind invitation. Special thanks to Eric Van Duren to introduce us for the V concept. I will show something that we have been working with the Brazilian team, Gustavo Giordani and Paulo Fernando and me. So my topic today will be prosthetic options for posterior and anterior restorations, the procedural aspect. I would like always to talk about 3 questions in each topic that I will talk today. And always we will mention when, what, why, and how we can use some procedures. So I would like to introduce 3 concepts in the restorative part. We'll talk about the retainer type, about the abutment type, and about the abutment material. We know that we have 2 choices in each one, in which topic. We have the screw restorations versus the cements. You can be screwer or cementer. We have the stock abutment versus custom abutment. We have to choose if we use one other one. And also we have metal versus ceramic. But we know, before we have to choose which one will be the kind or the type of the restoration that you use, we have to perform acceptable tissue surround about your implant restorations. And to provide this kind of tissue, we have to manage the tissue in the appropriate way. And to manage the tissue in the correct way, we have to take care about our provisional restorations. And to take care about that provisional restorations, we have to start sometimes customizing our type of restorations since the provisional phase. So now let's understand when, why, and how we have to customize it since the provisional phase. So pay attention now in 4 situations, 4 tooth that we struck it. And if you see, each one has a specific shape, as Professor Marinello mentioned for us before. So if we think that we have to deliver for the patient a natural restoration, we have to follow this kind of shape. And if we work with prefabricated abutments, it will be difficult to deliver acceptable restorations. And a lot of articles mention that if we work in the provisional phase with prefabricated abutments, to deliver a natural restoration, we have to spend a lot of appointments managing the tissue. And this can traumatize our soft tissue. So let's try to show some protocols that we can improve our tissue after the implant placement. And also, if we work with the final restoration, if you want to work with customizing abutments or a natural crown, we have to work with customizing abutment here. Because if we place a prefabricated, we have problems with cementation, we have problems to work with the crown. A lot of articles mention we can increase peri-implantitis if we work with a prefabricated abutments because it's difficult to remove the excess. And some articles also mention that we have more problems with the bone when we use prefabricated abutments. So we know that we have a lot of advantage to work with custom abutments. And if you want to have more accuracy to work with custom abutments, we start to do some experience. So if you go for your cast before you start your surgery, and you remove your tooth on top of the cast, you start to find different root shapes. It's the same that I showed you in the other slide. So if you want to create a protocol, you can improve your time working in the cast. And nowadays, you can work with DICON in Conbeam and also with some data for the scan your cast. If you work in this way, you have more accuracy in your restorations. And also, the risk assessment will be low because you work before. So the protocol that will show how you can manage the tissue with provisional restorations were based in some articles that they launched in maybe more 20 years ago. And also we have some data for CAD/CAM designs and some tissue managed for Sui, and one Spanish that called Oscar Gonzalez. And I'm happy that's the technique that we have been working. In this year, I tried to find some new articles about tissue management, and Fullhauser showed the cup root technique can have a good outcomes after 5 years. Also, Stefan Shu. So I think we are in good path. We are find some good ways. And if you cannot do the immediate loading, you can customize in your healing abutments. And this is the way that we have been working. So pay attention in this simple case that we do in our daily practice. So the patient loses the molar and the premolar. We work with Paulo Fernando from Implant Brazil. So Paulo placed 2V3 implants, and you can see that we have the implant now in the alveolus. If we go to the normal approach, you place some healing abutments, okay? And you know that after 4 months, you have this kind of tissue. And when we have this kind of tissue, we have to work a lot, maybe 3, 4 appointments to deliver a good restoration with a good contour. But we can accelerate this process. How we can do this? We can have our provisional abutment, we can create a layer on top of this abutment, and we will place the provisional abutment with flowable composite on top of the implant. And after this, we have to create a layer copying the alveolus with flowable composite. But we know that we can now be in a danger zone. So try always do this procedure to protect the alveolus with a sponge such as maybe a collagen sponge. We will protect the alveolus with collagen sponge, and after we will place the flowable simultaneously with curing. So we will place the flowable simultaneously with curing on top of the alveolus. After this, we'll go with one marker, and we will draw the alveolus here, and also create a point in the buccal part, because it's easy when we remove and to place again. After this, we will work with burr, rubbers, and we will perform these custom abutments. Okay? This is the approach. It's a simple approach. Instead, you use the normal and the usual approach. We start to use the customizing approach, and you can achieve a good outcome, an acceptable outcome 4 months after the implant placement. So you have 2 choices today, nowadays, to work with the MIS components. You can follow this way or the customizing way. I know that to work with provisionals, we have a lot of doubts, we have a lot of questions. So with Eric and other Brazilians, we want to go more further in this topic. So we start to do some experience. Our first experience, we tried to develop one alveolar model. So before we extract the tooth, we take one impression, okay? And after this, we will place the tooth inside the impression, like a cupping tray abutment. After this, we will pour one cast, okay? And after we pour the cast, we have this kind of alveolar model that we have the same thing in the mouth. After this, we will place the implant, and we will create a jig with 2 wings. And this jig will be to have more accuracy and to fit our cupping tray abutment in the model that we create before. And after this, we will stabilize the implant with some stone in the bottom and some flow in the top. We will have our crown, natural crown, and we will cut and place on top the provisional abutment. And now you can see we have figure number 1 and figure number 2. If you compare, number 2 is the same tooth, but on top the provisional abutment. And now we have to understand when we can manage the tissue. If you see, line A is the gingival level. Line B is 1 millimeter of the gingival level. And we have to play just in the letter C. Because if we play the letter C when you see in the sagittal view, we will create a concavity. That concavity has the function for provide a clot or also a space for the soft tissue graft. And if you see in the frontal way, we will remove the sharp angles, the square angles here, to provide a smooth area for our provisionals. So the way that we have been working, even in posterior or anteriors, you can see we place the implant maybe 4 millimeters from the gingival level. So the first millimeter will maintain the same shape. 2 millimeters deep, we will create that concavity. And the 1 millimeter will be for the polish area, for improve the V-concept, and also to improve the tissue surround the implant. Okay? In the sagittal view, we have this view. In the frontal view, we have to remove the square angles. Okay? And also, if you want to provide some, if you want to gain, or if you want the tissue come a little bit coronally, you can remove a little bit in the area of the emergence profile. You can create the emergence profile a little bit straight so the gingiva can go coronally. So that way we can improve our tissue surround the implant. And I know that this is a little bit like difficult for us, no? It's too much work. But this is an analogic protocol that we have been working, and now I think Eric can explain later, because now we start to work with CAD/CAM, and also we can mill in our abutment, and if you compare our abutment in the alveolar model, we have that it's almost ideal situation. So I think this will be the future, and we have published these things in KDT and also in a Brazilian magazine that I can give for you later. But focus in that table now. If we work with stock abutment, we know that the cost is better, but the problem is to manage the margin. I can work with stock, but for me and for our group, more when someone referred the implant for us, the implant is the same level of the gingiva, so I don't need to manage the gingiva, so we work with stock abutments. But when I want to customize, when I have to have the ideal situation, I have to use the custom abutment because I can control the tissue, I can have better outcome. Unfortunately, the time, we spend more time, and also the cost is a little bit high, okay? We use always when we have to manipulate the tissue, and we have to take care about the impression, the lab phase, and if it's possible, try to do the abutment with CAD/CAM design. About the custom, so why? Because we can improve our tissue support, the architecture, we can earn aesthetics. Oh, sorry, I'm a little bit nervous, but now back again. And we can improve tissue support, tissue architecture. We can have better aesthetic outcomes. You can improve the final management for the crown for the technician work in the lab. When you use always and how, because manage the tissue during the phase, the provisional phase will be better for work with custom abutments. So our group prefer to use custom abutments for the final restorations. About the type of our restorations, we have screw or cement. Which one will we use? If you go for that table that I have been working with my friend from Barcelona, Álvaro Blasi, we have pros, screw, like Marinello, Professor Marinello mentioned, we have retrievability. So it's easy to do the maintenance. But the problem sometimes is the holes, no? Because to close the hole, sometimes to assess the hole, we can have some problems. But if you work with CAD/CAM, like he mentioned, we can have more retrievability and we can repair easily. The tip maybe to work with this, try to have a good communication with your lab, because sometimes the technicians work with a thin screwdriver. And the screwdriver that we have in our office sometimes is too thick. And if you place or do some wrong movement, you can provide some chip or some crack in our restorations. Try to talk with this with your technician. About the cement restorations, the good thing that we have less disconnections. We can work one abutment on time. It's better. But the problem is the residual excess cement, that it's difficult and sometimes we can have some problems with this. We will use this when we have the hole a little bit facial or buccal, and we have to take care about the abutment design, the cement that we will use, and also the protocol that we will cement, okay? So why, what, and when, and how we can use this, because we have more retrievability. We work, oh, again, sorry, nervous, about, no, okay. Without cement, easier maintenance, always when we have the implant in correct position. And to work with this, we know that if we work with 3D softwares and surgical guides, we will achieve this outcome. Now let's talk about the abutment material a little bit. And about the abutment material, we can see that metal, the cost and the strength is an advantage. The problem is the color, because we know that the patients now sometimes can complain. We work more in no static areas, okay? And we talk with the technician to have a correct polish. The ceramic, we have biocompatibility. We can have more cost. Sometimes you know that the ceramic is more friability. We have more problem with flexure. We have good statics, and we can work with CAD/CAM. If we go further, we know that ceramic, we can work with 2 millimeters, more than 2 or less than 2 millimeters, because they have a good color. Metal, no. We have to work always with when we have more than 2 millimeters. Otherwise, we have problem with color. The ceramic, we know that we have to have the ideal thickness to work with ceramic. Otherwise, we can have problems with fracture. With metal, we can work whatever thickness. And with patients that we have high function, may better work with metal. And with zirconia, we can increase the risk assessment. Okay? With options, we can work in our practice. As I mentioned, we prefer to use custom and screw. So MIS provide for us these options of components. We have the stock abutment, we have the gold or the chrome cobalt that we can cast, we have the tie base 4 millimeters, we have the tie base 6 millimeters. We can play also with this area of the neck, with the polish area. We have the provisional cylinder, and we have also prefabricated zirconia abutments. And how we can take advantage of this? I know that some people maybe can ask, but how about the full zirconia abutments? Alvaro is a friend that worked with a pros, with a lot of oral rehabilitation, and he mentioned with me that he had some problems in patients with high function that broke the zirconia abutments. And he mentioned also to me that it's so difficult to remove this. And sometimes if we not see that it start to break, the patient start to have some wear in the implant area and can have some pigmentation in the tissue, because zirconia with implant can damage the implant, okay? So we know that when we work with restorations on top the implants, we have a high risk assessment to have failure. So how we can improve this? We can place a metal link or a T-base between our zirconia restorations. And this was the approach that Alvaro used in that case, and he told me that now he has better outcome. So when we think in this kind of restorations, I would like to think, always when you do a restoration, failure will happen. And we have to design our restorations to avoid failure and to have more success. And we have to find where will be the weak link, and we have to do the restoration that can be retrievable in the easy way. So if we work with this kind of restorations, that we have the tie base, we will screw the tie base, and we will cement the monolithic, full crown zirconia or disilicate on top of the T-base. And with cement, zirconia or disilicate on top of the T-base, which will be the weak link, okay? Where is the weak link is located? And if we have some failure, how we can manage this failure? So with the normal options for posterior restorations, we have the cast, we can do metal restorations, we can place zirconia on top of the T-base, or we can use the prefabricated zirconia and place monolithic disilicate on top. And now you have to think, where is the weak link? Because if you work with metal, the weak link probably will be a chip on the layer ceramic part. And if you have a chip in a metal restoration, you have to replace. But if you work with tie base, with zirconia or disilicate, lithium disilicate, if you have one problem, probably the problem will be the bone. It's difficult to fracture the disilicate or the zirconia restorations. So if you have a deep bone here, you have to bond again. You have to cement again. So your risk assessment will be low. And also will be retrievable, and to manage this failure is easier. If you have one problem with the crown, you can mill in again from the CAD-CAM, and you have a new restoration in the easy way. So this is our options. And as I mentioned, the problem sometimes could be when you cement. So to achieve a good outcome when you cement the zirconia on top the tie base, we have the advantage in the MIS components that when we place the tie base on top the analog, we have this kind of tie base, and also the tie base has one concavity here that will guide us to cement the restorations. And you have to take care to clean a lot the tie base. You can also place to improve the macro and micro retention. You can place some monomer with 10 MDP, like Monobone Plus or alloy primer from Curaray. And you have to use also a cement with 10 MDP, like Multilink hybrid implant or Panavia V5. So if you work in this way, you can have a good bonding. It's not bonding, we can good macro and micro retention between zirconia and the metal part. Victor, how about do a sandblaster on top the tie base? If you do sandblaster on top the tie base, we have the advantage the tie base is gold color. If we sandblaster, maybe it will be grayish. So I try to take advantage with the color to avoid some grayish of my component. So I prefer just clean a lot, maybe with ultrasonic or steamer. And after this, use a protocol that I use 10 MDP and also cement with 10 MDP. So if we don't have adhesion between the zirconia or the disilicate with the metal, we have to back to the basics. We have to think that our tie base with our zirconia crowns, we have to back to the basic and think in 3 topics. The axial surface, our tie base have to be parallel, okay? We have to think about the length of our tie base with the anatomic crown, and also how we can improve the surface area. So we know that our tie base is parallel, so we have a good axial surface. We know that our tie base has some macro rotations, and we can improve the micro rotations with 10 MDP. But now, how about the length? We know that we have 4 and 6 millimeters of length. So when you planning a restoration in the posterior area, try to think in this way. You will place the implant 3 or 4 millimeters from the gingiva, and you have your final anatomic crown. Try to do a math and understand how will be your total length of your final crown. So we can suppose that we have like, premolars has the average with 8 millimeters, okay? If we place the implant 3 millimeters, we have 11 millimeters. So you can use a tie base with 6 millimeters that you can achieve your tie base close to the fossa, but also you can work with your tie base with 4 millimeters, because 4 millimeters will be half than 8 millimeters. So the math, I know that it's too fast, but try to take home these things. Tie base, at least half of size of your anatomic crown to improve your mechanical and micro retentions. So in situation like that, which material I have to choose? Our group prefer to use tie base with lithium disilicate or zirconia in the monolithic way, just layer, okay? Let's see a clinical case now in the anterior area. We have this kind of patient that will have to extract the lateral, and we have to place some veneers on the anterior area. So we remove the lateral, we did our jig with wings, we provide alveolar model, we made that provisional following the rules that we mentioned before, and using this way the plastic cylinder provisional that MIS has. and we have this kind of tissue after 4 months. I always prefer to remove the provisional at least 4 months before surgery because I can manage the tissue better. Okay? So this is before extraction, alveolar molar situation, and after 4 months. And now I have to prep my veneers. Now to improve and to do a minimal preparations, we bleach it a little bit the tooth. We earn a little bit. We improve the color. So now I have to prep less. Okay, we did some additive wax with Cristiano Soares from Brazil. And now I have to decide if I have to place post or no. I can see that I have 3 millimeters of thickness. I have to prep 0.8, so I don't need to place post, and also I can place a veneer. We start to create our protocol to prep on top the mock-up, as Professor Galip Gurel mentioned 10 years ago. We create some grooves. We create a horizontal path of insertion. So we work with this kind of burrs to close the black space that we have when we work between implants and teeth. Sometimes we have problems in this area, so we go a little bit further in the contact points. You can see that we have our preps here a little bit more conservative than here, that the tooth is a little bit dark. So we take the impression. After this, we work in the CAD/CAM, and we perform the way that we mentioned. You use the tie base with 6 millimeters. We made a custom zirconia abutment on top the tie base, and we bond with 10 MDP, and also with a cement that has 10 MDP. For the restorations, we work with a monolithic disilicate, and we placed our restoration in the screw way, because we know the advantage that we can take with this situation. For the tooth, we stand in, we bond, and this is before and after. This is a lateral view about our tissue, before and after, and this is the picture that I like because we can see in the right side, in the left side of you, the implant tissue, and now the natural root tissue. So if we follow some steps, if we work with the tissue in the correct way, we can achieve a acceptable outcome. So the question that we mentioned before, what is the V concept? For me, it is a concept to perform better outcomes in our daily practice. When? You used to use when you want to optimize the tissue, volume, color, and steady outcomes. Why? Because we can improve the longevity of our restorations, and how? Using the customized soft tissue approach. So I hope that I can explain a little bit the way that our team works. Thank you, MIS, for that kind invitation, and have a good Congress.